Hi everyone, this is Neel Raithatha, consultant audiologist and director of Clearwax. Thank you for joining me in my latest video using the iClearscope endoscope. And here we have a patient who attended with otalgia, so ear pain, and you can see why. So they've got this really dry plug of wax skin, really impacted, and you can actually see the indentation in the center where they used a cotton bud. And initially this patient advised me that they didn't, but they later admitted that they did. But it was very apparent just by how impacted it was, this indentation in the center, where this is where the cotton bud was used to push the wax further in. Of course, the patient didn't intentionally push the wax in. They believe by using a cotton bud, they can remove the wax, but a cotton bud is, and in America it's called a Q-tip, a cotton swab. It's only going to further impact the wax in. And as soon as I made contact with this wax, with the suction probe, it was too dry, too impacted. So initially I instilled some medical grade olive oil spray to loosen it, but I had to revert to the Rai Curette on several occasions now. I typically don't use the Curette initially to do what I'm doing right now, which is elevating this compressed wax skin off the canal wall. And the reason for that is that whenever you make contact with the canal wall, which is obviously what we were having to do with the Curette, you can cause some discomfort to the patient because you're trying to glide the instrument in between the earwax and the canal wall, and the inner 2/3 of the ear canal in particular, so the osseous portion, is very sensitive, and that's because lining the osseous portion of the ear canal is a very, very thin, delicate layer of skin, epidermal skin, and it's less than approximately 0.1 millimeters in thickness. Now, on the outer third, the cartilaginous portion, you've got a much thicker layer of skin. It's about 1 millimeters in thickness. And that skin has 3 layers. You've got the epidermis layer, which is the same layer of skin that lines the bony portion of the ear canal. The dermis layer, where you have your elastin, collagen, and your hair follicles. And then underneath that, you've got your subcutaneous layer or a hypodermis layer, which contains adipose fatty tissue predominantly. So it kind of creates a buffer. And of course, cartilage is more flexible and malleable, less rigid than bone. So this patient was in so much pain that at the beginning of the procedure anyway, because the patient was very nervous, they were holding their partner's hand. So I didn't want to use the Curette if it were possible. If I was able to peel away some of this wax and skin using the suction tip, that was my preferred method. And that's because sometimes it is possible to elevate the wax and keratin using the end of the suction tip. And when doing so, you can just hover over the canal wall, so you're not always having to make direct contact. So there's less risk of causing discomfort to the patient. And you'll see during the procedure, I initially used the Curette, lifted it, then reverted back to the suction probe to see if I could remove it. So I was kind of alternating between the Curette and the suction probe. There was a moment just before where you kind of saw the camera wobble, and that's just because we suctioned a bit of wax and it travelled up the suction tube and it startled the patient slightly. So that was the reason for that. I've just applied some more oil now because we've lifted some of this wax off the canal wall. I was hoping that some of the oil can seep underneath and behind the wax and keratin. It just got a bit blurry there, so it just came out. So we can see half the eardrum, so already they could hear significantly better. But of course, we want to try and remove the majority of this. They have got a very mild attic retraction. They attended about a year or 2 ago, and they had acute otitis media in this ear. It was probably around the same time as well, so it was in December time. Performed tympanometry, and they have normal middle ear function, and the air pressure is equal either side of the eardrum, which suggests that their eustachian tube, which is the pressure equalizing tube, is functioning. So again, I'm having to revert to the Rai Curette and just gliding up the floor of the ear canal. We are on the bony part, but the patient found it very comfortable. And in part, that's due to the design of the Rai Curette. I've added a bit of curvature, and hopefully you can see it there, and that curvature is designed to mimic the curvature of the ear canal itself. Most Curettes are flat, so the sides of it can rub against the sides of the ear canal. But by having this curved Curette, there's less friction, less contact with the bony part of the ear canal in particular. So it worked really, really well. So again, I've lifted it, elevated this compressed impacted wax skin off the canal wall, and just reverting back to microsuction here. I'm giving it a good wriggle. You can see it gives you an idea of how impacted this was. And this patient did use cotton buds previously as well, so just advise them to stay away from it. The husband was, as I mentioned, in attendance, and he solemnly promised that he will get rid of all the cotton buds from the house. His wife can't use it. So I've got the occlusion's gone now, but I just want to remove some of this embedded keratin in the canal wall. Sometimes when it's embedded like this, it's going to be hard for it to naturally migrate, and then it can potentially lead to a kind of a follow-up, a build-up of wax quicker than usual. So just by removing this, hopefully it will allow the natural epithelial migration. So the skin that lines the ear canal, it naturally migrates sideways from the deepest portion of the eardrum, actually. So all this skin was once formed at the center of the eardrum, and once the skin is formed and secreted, it radially migrates off the eardrum. And what I mean by that is, imagine if you've got a pond or a little puddle and you drop a pebble in the center, you'll have those ripple effects. And similarly, that's how the skin migrates off the eardrum once it's formed at the center of the eardrum, the region we call the umbo. And then the skin then migrates from the deepest regions of the ear canal towards the entrance, where then the individual skin cells detach itself from one another, and they eventually just naturally fall out and migrate out the ear canal. So I'm just mopping up a bit of skin here at the entrance. I've got quite a bendy ear canal. So there's a bit there just anteriorly, the eardrum's fine. There's a ditch, a little depression in the floor of the ear canal, but it's the underlying bone is not exposed. There's no ulceration, there's no infection here. So it could be due to pressure necrosis. When the wax sometimes is really impacted against the canal wall, it can cause a bit of pressure necrosis. It could also be benign osteonecrosis. Well, I hope you enjoyed that video, guys. Take care, keep well.